So without further ado, cancer genetics and genetic testing, it's not all in the family, with Kate Foreman, MS, CGC. And let's learn a little bit more about our presenter. Kate Foreman is a genetic counselor and clinical assistant professor at the UNC School of Medicine in the Department of Genetics. Kate received her master's degree in genetic counseling from the University of North Carolina at Greensboro in 2009. She joined the faculty at UNC Chapel Hill shortly thereafter. Kate received her certification from the American Board of Genetic Counseling in 2010. In her clinical work at UNC, Kate provides genetic services in the cancer and adult general genetics clinics. She has an interest in pediatric genetics and has a monthly pediatric cancer clinic and maintains involvement in the pediatric tumor board at UNC. Kate is involved in the teaching and clinical supervision of genetic counseling graduate students. She teaches Introduction to Oncology and Genetic Counseling at her alma mater, UNCG. Kate's research interests include genetic applications of next-generation sequencing technologies, including the handling of secondary findings. Kate, welcome. Thank you so much for being here today.
And thank you for having me.
Absolutely. We're thrilled to have you here. What's something we should know about you outside of your professional bio there?
Well, I'm a person who has always loved dabbling in art, going back to my elementary school days. But I recently decided to invite that back into my life, and I'm taking an online painting and mixed media art course. So on my disclosure slide, you all will be able to see one of my recent works.
Good for you. That is great. And let me just going to, I'll talk about Poll Everywhere for a second, and then we actually get to see a piece of Kate's work. So all cancer, the Poll Everywhere question that we'll start with, this is just a placeholder slide here. All cancer has a hereditary component. A, true, B, false. We'll let you think about that, and then you'll be able to answer that in Poll Everywhere in a moment. And then I'm going to say that this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Greensboro Area Health Education Center is approved as a provider of nursing continuing professional development by the North Carolina Nurses Association, an accredited approver of the American Nurses Credentialing Center's Commission on Accreditation. Kate Foreman, MS, CGC, has no relevant financial relationships with commercial interests as defined by the ACCME. And let's take a look at that Poll Everywhere question. Kate, I'm seeing a trend here. Folks are saying all cancer has a hereditary component, and it looks like the majority are saying false. How are they doing?
Yeah, and that's the correct response. For folks who were thinking that there's a hereditary component to all cancers, don't worry, we're going to cover that shortly. And it is certainly true that all cancer is genetic, although it doesn't all have a hereditary component.
Okay, good to know. And without further ado, and they'll get to see that picture in a minute as well, cancer genetics and genetic testing, it's not all in the family. I'll turn it over to you.
Yeah, thank you. So in addition to my lack of financial disclosures, I did want to make folks know that I am using real patient test reports de-identified in this presentation, and you may be able to recognize the laboratory based on the style of the reports or other features. Don't take that as a personal endorsement of any of these labs over others. There are also great options that I just didn't happen to have reports on hand for. So today we are going to do that brief cancer genetics refresher I mentioned before we get into the meat of the talk, where I'll be talking to you about oncology genetic tests that are in major use today, as well as presenting some case reports where inappropriate or misinterpreted testing has the potential to lead to patient harm. We will close out today with tips for hereditary cancer risk assessment and genetic testing and some practice resources. So coming back to our first poll question, all cancer is genetic, but not all cancer is hereditary. at least in the way that we currently define it, where a genetic variant has a significant impact on cancer risk. About 5 to 10% of cancers, though, do have an underlying hereditary cause or etiology. That does vary by cancer type. That holds true for breast cancers, for example, but there are other types like ovarian cancers and pancreatic cancers where a greater portion of those have an underlying genetic etiology. When I'm talking about underlying genetic etiologies, right now that mainly means single gene hereditary conditions. This is a little bit of a complicated slide, so we're going to work it through bit by bit. But suffice it to say that even in cases where there is a hereditary risk factor, development of cancer is multifactorial. So imagine that these 4 cups are 4 different people and their intrinsic ability to tolerate cancer risk. If the cup gets filled up to the top, a cancer would develop. All of these marbles represent hereditary risk factors. There are also probably hereditary protective factors, but those are harder to identify and describe. And those risks can vary both in the number of risks that are present per person, as well as the strength or the magnitude of those risks as represented by marble size. Even in the folks who have the highest degree of hereditary risk, like that cup all the way over on the right, the cup is not completely full. It's not at capacity yet. So the water filling the cup, all the other non-hereditary risks, are things like environmental exposures, some modifiable like smoking history, others less modifiable like our exposure to background radiation, and some of them completely outside of our control. All cancer development has a hefty component of chance as well. If we're exposed to a carcinogen that's going to induce a mutation in a cell, does that mutation happen somewhere that's important for cancer development, in a gene that's associated with cell growth or regulation, or does it happen in a benign location and have no ill health effect? Hopefully you can appreciate from this slide that people can have different magnitudes of genetic risk. Our current hereditary cancer genetic testing does a good job of identifying the largest marbles, things like BRCA1 and BRCA2, hereditary breast and ovarian cancer syndrome. And increasingly, we also identify medium-sized marbles, what might be called moderate penetrance cancer syndromes. And an example of that would be loss of function type variants in the CHEK2 gene. Currently, we don't have good clinical ways of assessing the little marble risk or polygenic risk. There certainly are clinically available products out there that try to make an assessment of high, average, or low cancer risk on the basis of those little marble type risk factors. But many professional organizations and groups like National Comprehensive Cancer Network have recommended against routine clinical use of polygenic risk at this point in time. Our ability to interpret those findings is just limited. So the hereditary cancer syndromes, those big and medium-sized marbles, are mostly inherited in an autosomal dominant fashion. This is represented in this illustration by parent A, who is unaffected and has 2 typical alleles or gene copies, copy 1 and 2. Parent B, on the other hand, has a pathogenic variant that causes a hereditary cancer syndrome on their second allele, allele 2. So the affected parent can pass along their working copy of the gene, along with either A1 or A2 from the other parent, or they can pass on their copy of the gene that has the genetic variant. That might be entirely non-working, or it may be producing a protein that's just less efficient at its typical cancer-fighting job. But all of that boils down to, in dominant inheritance, each child having a 50-50 risk of inheriting the parent's condition, like a flip of the coin. This is going to be important to keep in the back of your head because it will be reflected later in how we might identify hereditary risks from different types of genetic testing, including tumor or somatic testing. How do we find those pathogenic variants, though? How do we identify hereditary cancer syndromes? That happens through genetic testing, which is essentially a two-step process. It starts with a sequencing step, and then it's followed by a variant classification step. So first you have to find the genetic variants, then you have to determine whether or not they are clinically meaningful. The picture on your slide now is giving you a high-level look at what massively parallel sequencing or next-generation sequencing looks like. So we have a reference genome that is reflected across the top in the colorful A's, G's, T's, and C's that make up the genetic code. And then we sequence someone's genetic information in short reads of 150 to 250 so letters of genetic code. Those reads then need to be mapped back to the reference. So you'll see that they're kind of stacked up, somewhat overlapping with the different blue and red bars. Where those blue and red bars are plain, where they're solid colored, that means that the person being sequenced has the reference genetic code. So whatever nucleotide they have at that position is what we expect to see based on the reference. But if they have a genetic variant, which is represented kind of in the middle of the screen with the letter T, where the reference has a letter C, that will be noted as well. And here you can see that T is in approximately 50% of the reads if you just move your eye down that column. So that could be consistent with a germline or hereditary genetic variant. Arguably, though, the variant classification is the more difficult step. We are very good at sequencing and finding these genetic variants, but sometimes it's difficult to determine if they're clinically relevant for patients. Most of our genetic variants are not harmful, are benign. But we do have good guidance for doing that as well. In 2015, the American College of Medical Genetics and Genomics, along with the American Molecular Pathology Association, they published joint recommendations and guidelines for variant interpretation. And most labs are now using these categorizations. It's a 5-bin classification system. Pathogenic or harmful genetic variants are those where we are confident that they impact the protein function to the extent that they cause inherited or genetic disease. Likely pathogenic are the same, usually with 90 to 95% confidence, but lacking the amount of data to definitively call them pathogenic at the present time. The flip side of the spectrum, you have your benign or harmless variants, and your likely benign variants that are 90 to 95% likely to be benign. And in the middle of that scale, you have variants of uncertain significance. Any genetic variant that's identified by a lab for which they have insufficient evidence to put it into one of the other bins or categories. By convention, only variants of uncertain significance or higher are going to appear on genetic testing reports. All of us have benign variants, and our reports would be 2 or 3 times as long if they were including all the benign and likely benign variants on there as well. How do we classify these variants? We use lots of different types of data. We might use experimental evidence. So have they looked at what the protein actually looks like if you induce that variant in a laboratory scenario or in a model organism? We use the personal medical history of the patients being sequenced and their family history. And we also might use population data. So if you have found a genetic variant and it's in the BRCA1 gene, a gene that's associated with a high penetrance breast and ovarian cancer syndrome, and you look in a population database and find that your variant of interest is in 5% of people in that database, it almost by definition couldn't cause that very rare hereditary cancer syndrome. So high population frequency is strong evidence that a variant is benign or harmless. On the flip side, if that variant has never been reported before in our population databases, that is moderate evidence that it could be pathogenic or disease-causing. No one piece of evidence is typically going to be the sole reason that a variant is classified one way or the other. But I like to give this as an example for folks to understand why you might see a genetic variant and think, well, my patient has breast cancer, it's in a breast cancer gene, why aren't they saying it's the cause? And it can be because of issues like this, where the data might be mixed or insufficient to call it in one direction. I do also want to take a minute to point out again that although there are 5 categories here, genetic variants are not evenly distributed across all 5 of these categories. Once again, most of our genetic variants are benign. They simply account for the differences between people and families. So in that same way, variants of uncertain significance are not equally likely to be benign or pathogenic. Actually, 90% of the time when variants of uncertain significance identified in hereditary cancer genes are reclassified, they end up being downgraded. So again, just because we have seen a variant in a gene of interest, that in and of itself doesn't make it more likely to be pathogenic. The genome's a big place and coincidences are going to happen. So with that, I'd like to talk about 3 different categories of genetic tests that are commonly used in oncology today, and all of them are really founded in that massively parallel or next generation type of sequencing. 15 or so years ago, if you asked whether a patient with cancer had had genetic testing, we would know that you were talking about germline or hereditary cancer testing. And actually back then, if you didn't specify another gene or condition, if you were just asking about, well, did they have the cancer genetic test, you were probably talking about BRCA1 and BRCA2. Although this is hereditary cancer risk information, it does still provide useful information to the patient with cancer themselves. Might they be at risk for a new primary, either in the same organ or in a different organ? Do these variants inform their treatment? And what is the information that can help their family members? The most common sample for this is white blood cells or skin fibroblasts coming from saliva. It is not appropriate, though, to use blood or saliva specimens in people with an active leukemia or in people who have a history of bone marrow transplant. So then we need to do skin fibroblast biopsy and culture to get an appropriate sample. Not long after germline genetic testing was widespread, tumor testing became more common as well. This is also sometimes called somatic testing, so germline having to do with the germ cells or the reproductive cells, hereditary genetic variants, somatic having to do with the body or soma, things that are likely confined to a tumor and not hereditary. And the main goal of this type of testing is usually to identify targeted therapies that can benefit our patients. There are potentially other uses as well. Sometimes you might identify a metastasis and not know the primary origin, but looking at a molecular signature can help inform that, get you an accurate diagnosis. As the name suggests, the specimen type for this type of testing is tumor. Some labs will request a blood sample alongside. Usually that is just to aid them in their interpretation, so they can prioritize the variants that are truly somatic, ones that are new to the tumor and thus more likely to be driving that carcinogenesis or that malignancy. Rarely, though, a tumor testing lab will offer true germline genetic testing alongside the tumor sequencing they're doing. Cell-free DNA testing is the newest of these technologies to be introduced into the clinic. This type of testing identifies fragments of genetic information that's outside of cells but circulating in the plasma. Sometimes you will hear this referred to as liquid biopsy testing. It often has overlapping goals to the goals of tumor testing. You're trying to identify targeted therapies. You may be trying to get an accurate diagnosis. But because this is a less invasive way of obtaining a sample, it's also useful for monitoring of minimal residual disease. This will not be the focus of today's talk, but there is a lot of interest in seeing whether cell-free DNA testing might be able to be useful employed in the general population as a type of cancer screening. But we're talking today about applications in folks who have a cancer diagnosis. Again, the sample for this is blood, and they're specifically looking at the genetic fragments in plasma. I do think, though, that this type of testing has introduced a lot more confusion into the question of, well, has the patient had genetic testing than tumor testing did? Although with tumor testing, patients were sometimes providing a blood sample as well, it was easier for providers to differentiate and for people to explain to a patient if they had misunderstood what that type of testing was looking at. But with the cell-free DNA testing, since it's also just a blood draw, no tumor being sent, I think it makes it a lot more complicated to identify the right tests. And some of our genetic testing labs are not making that easier on us. As I mentioned before, some labs are starting to try to be one-stop shops for hereditary and somatic genetic testing, whether that be by tumor or cell-free DNA testing. And they do not always do a good job of explaining their methodologies, the scope, or the sensitivity of their germline testing. It can be really hard sometimes to identify by test name what exactly is being looked at and done. So we will start by doing a little bit of a deeper dive into germline testing. And as a genetic counselor, this is where my practice began. So we will talk about this a little bit more than the other types of testing. First thing to do is to identify which patient's germline or hereditary testing is most appropriate for. Germline genetic testing is still best applied in patients that have increased risk of having a hereditary cancer syndrome. We're not quite yet at the place where we're doing this as a population screen. Some organizations like NCCN will provide guidelines that are organ specific about what qualifies someone to get genetic testing. For rarer hereditary cancer syndromes, Gene Reviews is a good resource as well. But thinking big picture, here are some of the hereditary cancer red flags. You're looking for families that have more than their fair share of cancers, particularly if it's the same type of cancer or types of cancer that are known to be associated within the same syndrome. Think breast and ovarian cancer with BRCA, breast and pancreatic cancer with PALB2. We sometimes see multiple primaries in one person, so people at high genetic risk, not much has to happen to kick them over the threshold to getting a second malignancy. We also see earlier ages of diagnosis among the hereditary risk cohort, although having a typical age of diagnosis by no means rules out the possibility of an underlying hereditary risk. We will also see unusual features sometimes in families. That could be things like cancers in a less affected sex, male breast cancer, or particular tumor types that have a higher rate of underlying hereditary risk. Sometimes those are whole classes of cancer, like exocrine pancreatic cancers. Sometimes they're subtypes, like triple negative breast cancer. It's also important to mention that ideally testing should occur first in people who are affected with cancer. Sometimes patients and sometimes providers come to us in genetics and they say, well, my patient has cancer, they're really overwhelmed, not sure if it makes sense to do genetic testing at this point. And we certainly hear those concerns. But at the same time, a lot of folks are interested in this genetic information, not only for themselves, but for their close relatives who might be at risk. And it's much easier and more informative to interpret genetic test results in folks who have had cancer. If I'm testing someone without cancer and they get a negative genetic test result, I don't know whether to throw them a party because they're not at risk or to exercise more caution because it could be an uninformative negative. Similarly, those variants of uncertain significance, it's usually easier to piece those out if we start with someone who's had cancer. I think we've touched on benefits already. For patients with cancer, we can influence their treatment decision. Sometimes that's with targeted therapeutics, but sometimes it's giving them the benefit of making different surgical decisions. The exemplar of that is probably choosing prophylactic contralateral mastectomy at the time of initial surgery for treatment of breast cancer in women who have BRCA1 or 2 pathogenic variants. Similarly, depending on the prognosis of your patient, they might be surveilled differently after their cancer treatment or have other risk reduction opportunities if they're at risk for other primaries. And we can't discount either the psychosocial benefit of being provided an explanation through genetic testing. I think this is often more beneficial in folks who are young for their cancer type or people who have significant family histories of cancer, and these are actually the folks we're most likely to find hereditary risk in as well. There are also benefits to the unaffected relatives, the availability of increased and early surveillance, risk reduction opportunities, and just life and family planning that having that sort of knowledge affords. These benefits so far, they really have focused on people in whom we do identify hereditary cancer risk, but it is worth noting that most genetic testing we run is negative or normal, and most of those negative normal tests are reassuring when taken in the context of the patient's medical and family history. So there certainly is also benefit to getting a reassuring normal result where people realize that they aren't at especially increased risk for future primaries, or they don't necessarily have to worry about their unaffected relatives as much. I'm not going to talk a lot about specific genetic testing products, but it is helpful to note that there are a wide range of tests that are available. Nowadays, single gene testing is very uncommon, but it could be the appropriate testing type for someone whose medical and family history is very specific for a particular hereditary cancer syndrome. Disease-specific panels for most patients are going to strike the right balance of looking broadly at all the things that could make a difference to their management while restricting uncertainty and off-target results. But because of this massively parallel sequencing technology, it is not difficult to look at dozens or even hundreds of genes at once. So there are clinically available multi-cancer panels that have 75 plus genes on them that can all be analyzed simultaneously. You will probably have already guessed from the way I described disease-specific panels as being ideal for most patients that I do not think bigger is always better. Certainly you have an increased rate of variants of uncertain significance. The more genes you look at, the more likelihood of finding one of those. And on the largest clinically available panels, we have a VUS rate of 25 to 30%. So as many as 1 in 3 patients getting those tests will be returned an uncertain result. Furthermore, because our human reference genome is comprised mainly of data from European individuals, and because the bulk of sequence data available in population databases also comes from Europeans, the brunt of that uncertain information is disproportionately borne by people who are from non-European backgrounds, which I think is a problem. In addition to that variant level uncertainty, there are other types of uncertainty as well. So this is a test report from a family that I saw recently. I was seeing the child of a woman who had breast cancer, and that woman had a sister and mother who also had breast cancer. A fairly broad genetic testing panel was done in addition to a CHEK2 variant that likely explains or contributed to the breast cancers in the family. The test also identified a likely pathogenic variant in POT1. POT1 pathogenic variants are associated with increased risk of melanomas and brain tumors. Neither of those cancer types were present in my patient's family. It's a more recently described hereditary cancer syndrome, and most of the early reporting, most of our knowledge about penetrance, cancer risk associated with this gene, came from families who were enrolled in a familial brain tumor registry. So really there was an ascertainment bias where they were looking for POT1 in families who had lots of brain tumors, and then they said POT1 confers a very high brain tumor risk. But I have no idea if that data applies to my patient's family, where this was essentially an incidental finding, unrelated to the breast cancer history for which they were having testing. So I can't accurately describe to them what is their risk of melanoma, what is their risk of a brain tumor. And furthermore, there are no consensus guidelines for how we should manage that risk. So even if the risk is high, it's not clear that doing something like brain imaging is going to benefit those families. All of that is just to say, oftentimes both patients and providers will talk about bigger genetic testing panels as being selected because knowledge is power, but without full appreciation of some of the uncertainty you get on the back end, you might not really be appreciating what kind of knowledge or lack thereof you're going to get as a result. I'm going to go a little bit quickly through the germline genetic test reports just so we can spend some more time on our cases. But typically a report will be called positive if one or more likely pathogenic or pathogenic variants are identified. Negative results mean no variants were identified or only benign, likely benign variants. We've talked about uncertainty a lot, but there are also less common report types. Although less common, some of our hereditary cancer syndromes are recessive in nature, meaning you need 2 pathogenic variants to have disease. If only one such variant is identified, it might be reported as a carrier finding. Depending on the lab, those carrier findings may be their own separate report category, or they may be a subset of the positive results. And even positive results can have additional qualifiers. So if they call something a pathogenic low penetrance allele, that means that relative to other pathogenic variants within the same gene, this variant seems to confer lower risk. And then possibly mosaic findings mean that the allele fraction suggests that this may not be present in all the cells of the body. Perhaps this person didn't inherit their variant, but has it as the result of a new mutation, and thus it's present only in a portion of their cells. So this is just an example of a relatively straightforward positive result. A germline lab should be telling you the gene name, the specific variant or location in the gene where the alteration was found. They'll tell you the zygosity. If it's heterozygous, it was present in one copy of the gene. If it's homozygous, it's present in both copies. And they should give you a variant classification. The lab should be telling you, is this pathogenic, likely pathogenic, or something else? This is an example of one of those variants of uncertain significance. They will show as much information as they do for a positive result. They'll just be saying this is uncertain, and further down in the report, they'll describe where the uncertainty arises. Here's an example of one of our carrier results. MUTYH is associated with autosomal recessive polyposis. So this patient does not have that diagnosis, but they're a carrier for it. They could pass this on to children or grandchildren who might have MUTYH-associated polyposis. And then here's one of those positive results, but with the additional qualifier of low penetrance. Again, that low penetrance is gene-specific. CHEK2 is already moderate penetrance when you compare it to something like BRCA1 or BRCA2. So remember to think about those low penetrance qualifiers relative to other variants in that specific gene. We talked about this already with the marble example, but genes vary in risk, both the cancer types and the scale of the risk. So you could get a positive result that does not completely explain the cancer family history. You could also get a negative or normal result that's an uninformative negative, a family that has such a high cancer burden that in essence we don't believe that negative result. Or we believe that there's not a single gene hereditary risk factor, but that family appears to have high multifactorial risk and thus may still benefit from increased surveillance. So we have come to our first poll. When considering germline genetic testing, a germline genetic test performed in a patient with a cancer diagnosis, and you can choose A, will have either a positive or negative result. B, looks for the presence of a hereditary risk factor. C, does not have implications for treatment of the current cancer. Or D, is not necessary as the patient already has cancer. And we are getting the majority of folks very quickly arriving at the correct response. Germline genetic tests are intended to look for the presence of a hereditary risk factor. They sometimes, but do not always, result in a treatment of the current cancer. They are often necessary even though the patient already has cancer, both for benefit of the patient and for ease of interpretation for that patient and their other relatives. And we know that they would not just have a positive or negative result because uncertainty is always possible. So our next type of test, the tumor testing, I just want to look at this report really quick and point out a couple of things you will see on this testing type that you didn't see on the germline reports. So the germline reports are not going to be talking about biomarkers that are identified, therapeutic products. They won't be talking about the microsatellite stability or instability or a tumor mutation burden because, again, they're looking at constitutional DNA where we're not expecting to see these markers of carcinogenesis. You may see genes that are associated with hereditary cancer risk, but these findings don't necessarily mean that that patient has inherited risk. So both ATM and BRCA1 are genes that when there's a germline pathogenic variant can increase breast cancer risk among other cancer types. But somatic mutations are also possible and actually more frequent than germline variants in these genes at times. Tumor testing, while it's being done for targeted therapeutics, for clarifying a diagnosis or other reasons, can sometimes tell us information about germline status. A lot of that depends on the methodology. If they are using a true subtractive approach, where they take a blood sample, sequence that, and subtract out anything that's constitutional, so they're only focusing on the somatic variants in their analysis, it's unlikely that they would tell us anything about germline findings. Also, cancers don't always play by the rules. Cancer genetics can result in funny findings. Sometimes a hereditary genetic variant that's important to the early development of a cancer will be lost along the way and underrepresented if a tumor is at its later stages. So those germline mutations can, in a sense, be rescued or obscured by the behavior of the cancer itself. If you suspect a germline finding on the basis of tumor testing, it's important to independently confirm that. Because of that unusual nature of cancers, you can't assume that things that are looking germline actually are. And on the flip side to that, if a germline test is clinically indicated, if your patient's personal and family history are suggestive of hereditary risk, you shouldn't restrict testing just to what was found on tumor sequencing. And you certainly should not take a normal negative tumor sequencing test for germline findings as meaning that germline testing is not necessary. One of the major clues that something found on tumor may in fact be germline is that variant allele fraction that we mentioned at the beginning. So things that are constitutional are typically inherited either from our mother or from our father. So you're going to see about a 50% variant allele fraction. It's on one of the two alleles. There is variability there since each of those reads is either assessing the maternal or the paternal allele essentially at random. So anything in the 40 to 60% range could be indicative of something germline. Again, sometimes we see those germline variants at much lower than expected allele frequencies because of the unusual behavior of tumors, but 40 to 60% is kind of a safe range where it should be piquing our interest. Is the finding in a gene that's even associated with germline cancer risk? What is the relative frequency of that hereditary cancer syndrome versus finding a somatic variant in that gene? Some of our hereditary cancer genes are uncommonly mutated somatically in cancers. Other times, like TP53, we're going to find that very, very frequently in somatic samples, whereas the associated hereditary cancer syndrome is rare. Also, think about the fit between the syndrome and the patient or family history. Sometimes very good fit makes us more suspicious. But on the flip side, sometimes seeing a genetic variant that's not common in your patient's tumor type could mean that it's somatic. Could mean that it's germline, that is. So if a patient has, for example, a thyroid cancer, BRCA1 genetic variants aren't usually part of the carcinogenesis of thyroid cancers. So if you're seeing a BRCA1 variant, it's an incidental finding, but it could be representing a true germline hereditary risk that's just incidental to what cancer type they have. Here is another poll. So given that information I've shared, which result from a tumor genetic test is most likely to be confirmed in the patient as a germline variant in a patient with an endometrial cancer? You could choose a TP53 variant at 10% allele frequency, a TP53 variant at 45% allele frequency, BRCA1 at 10%, or BRCA1 at 45%. So everyone is identifying that important factor of what's our variant allele fraction. So 45 being in that 40 to 60% range, that's going to be more suspicious for germline risk. TP53 variants are pretty ubiquitous in cancers, and the associated syndrome is rare. So I would think that would be much less likely to confirm than a BRCA1 variant, pretty uncommon in an endometrial cancer, and that's more likely to be a true germline finding. Great job. Real quickly, the circulating cell-free DNA, because it has a lot of similarities to tumor sequencing. This DNA is coming partially from normal cells. In fact, germline genetic information is the bulk of our circulating cell-free DNA. But it also comes from cancer cells. And how much circulating tumor DNA is present is going to vary both on the tumor type and location and also the stage of that tumor, with more advanced tumors shedding more tumor DNA, more lysis of those cancer cells. Circulating cell-free DNA can also come from the placenta in pregnant women, and actually some of the earliest clinical applications of cell-free testing were in non-invasive prenatal screening during pregnancy. You can do with that DNA anything that you could do with white blood cell derived DNA. You can do targeted sequencing. You can do next generation sequencing. I'm not talking about it today, but methylation analysis is also a common tool that's applied to this circulating free DNA. While it does have many similarities to tumor testing, I wanted to highlight a few of the differences. Circulating tumor cell-free DNA is a less invasive test because we're looking at blood. We're not requiring a biopsy. Tumor testing is restricted to your location of biopsy. So you might be getting at one particular clone where another clone may be more important to this cancer and its future metastasis. Whereas with circulating tumor DNA, you're getting a more global picture of mutations all over the different clones of the cancer. Because of its invasiveness, tumor testing has a high threshold to repeat. You're going to require a biopsy or rebiopsy of that person, which might not be necessary for other reasons. Whereas there's lower threshold to repeat circulating tumor cell-free DNA just because of the ease of sample type. And then less important for patients with current cancer, but speaking to its applications as maybe a future cancer screening tool, with tumor testing, you need to find the tumor and biopsy it, while with circulating cell-free DNA, it's location agnostic. You pick it up in blood, and sometimes the DNA signature will tell you where to go looking for that tumor. The amount of circulating cellular tumor DNA, cell-free tumor DNA, relative to all of the cell-free DNA is very low. That is reflected in the left-hand side of this plot. So the little tiny gray peak on the left, those are the somatic variants, the variants that have low allele fractions and are not expected to be constitutional, but instead being tumor-derived. And then you have two much larger peaks, one in the center at 40 to 60% allele frequency, representing likely heterozygous germline variants, most of which are benign, and another peak on the right representing homozygous common germline variants, again, likely benign. Because there is so little circulating tumor DNA, some labs may enrich for the circulating tumor DNA. One way of doing that is to look at different fragment sizes, as that's different between tumor and germline fragments. But if they're doing one of those enrichment steps, it can sometimes obscure the allele frequency from us. So if it's a high allele frequency, but we've enriched to just look at tumor DNA, it may be less useful in helping us guess if a particular variant may be germline. So now we will go through our case studies. Case number 1 was a 64-year-old female patient who was referred to us in genetics for post-test counseling. What I knew from the referral is that she'd had triple-negative breast cancer about 3 years ago, and she had a sister with early onset ovarian cancer. And the referral said positive for BRCA1 and BRCA2. Many of you are probably familiar with BRCA1 and BRCA2. It increases a woman's risk of breast cancer, including contralateral breast cancer if they've already had one breast primary. Increases risk of ovarian cancer up to 40% or so for BRCA1, around 20% at the highest level for BRCA2, and to a lesser extent other cancers, including pancreatic cancer. Having BRCA1 and BRCA2 being a double heterozygote for both of those syndromes is possible, but as you can probably appreciate, is very uncommon. So on the basis of this high-risk genotype, the patient was advised to do risk reduction, and she chose bilateral mastectomy and a prophylactic salpingo-oophorectomy, so removal of the ovaries and tubes. The genetic counseling referral happened essentially after all of this, and it was largely to talk to her about risk to children and how she could tell her children about her results and the impact on her. But I had some red flags, and the very first thing I did was request the test report. I apologize for the quality of this, but this reflects real life practice, right? Sometimes we're getting a fax of a fax of a fax. But the first thing that I noticed were things like BRAF, this whole column of FDA targeted therapies, MSI and immunotherapy results. So this does not look like a germline genetic test to me. The second concerning thing is the low mutant fraction, which is the same thing as variant allele fraction, of 5% and 7% for these BRCA1 and 2 variants, not in the range that we would expect for a germline genetic variant. And furthermore, when I look up these variants, you'll see on this test, they're not telling me, are these pathogenic? Are they variants of uncertain significance? I had to go look that up for myself in a resource called ClinVar. The BRCA1 variant has been seen in folks in a germline state and is considered pathogenic, but the BRCA2 variant is considered a VUS. So lots of red flags going off. This was not a germline test. We do not know our patient's germline status, but she has been told, and she has had therapy, risk-reducing surgeries, on the basis of being a BRCA1 and 2 pathogenic variant carrier, which she may not be. In fact, probably is not. Where could we have stopped this? Because obviously harm happened to this patient. She had surgery she probably doesn't need. It was probably an inappropriate order, although the lab that the testing was performed at does have a germline product, so it's a little unclear to me whether the incorrect test was requested or the correct test was requested and there was a mix-up in the lab itself. In either event, the results were misinterpreted once they came back, so that was another opportunity to catch this. Referral to genetics was delayed, so they were prioritizing these risk-reducing procedures for the patient, thinking, well, genetics, they're just going to talk about the family, so we can do that later, and we could have caught this earlier. But then there were other providers involved. It wasn't just the oncology team ordering this. A breast surgeon did a surgery on the basis of this result. A GYN surgeon did a oophorectomy on the basis of this result. So did they get the report and misinterpret it? Or did they just take the oncologist's notes as being the record and move forward based on that? I'm going to skip this slide for time. Just to say at this point, we don't know where those BRCA2 variants came from, but being a germline finding is probably one of the lowest possibilities. There's probably a better explanation for why those were seen. I have another case of a 58-year-old man with a clear cell renal carcinoma, just stage 1. He had partial nephrectomy, no therapy was recommended, no systemic therapy, but he requested as much information as possible, so they ordered a combined tumor and germline test for him. Thinking very appropriately, the oncologist noted that this VHL frameshift variant was in the 40 to 60% range. And where they talked more about the variant, the lab says germline mutations in this gene are associated with VHL. And so they referred to the VHL Center of Excellence to consider disease-specific treatment. The VHL Center noticed, though, that this patient didn't seem to have VHL, referred to us in genetics, and we were able to confirm that the patient did not meet clinical diagnostic criteria for VHL. And further review of the testing showed that this was a tumor and germline test. And so the original test report stated that the VHL variant was not germline. Despite all, and I'll show you that tiny little sentence, no clinically significant germline variants were identified. But y'all, that one sentence was buried in a 12-page report. So I can totally understand why the provider saw those other signals and thought VHL was a possibility. Despite genetic counseling, the patient was very concerned about VHL and pursued self-pay testing as a second opinion, but did have a negative result as we expected. So this is our last question. A patient has been referred for consultation about risk-reducing mastectomy because of hereditary breast cancer risk. The best next step is to obtain a copy of that report, ask the patient, well, is it BRCA1 or BRCA2? Read the referring provider's clinic note, or seek consultation with genetics. Great job, y'all. Get the report. The report is always going to be the most important next step. Then if there's trouble understanding the report, you can get genetics involved, but that's going to be our first question as well. Well, where's the report? What does it say? Your tips and resources have a low threshold for involving us. There's a lot we can do to help you, whether it's meeting with the patient or doing an e-consult. Aim for a match between your patient's expectations and what they get. So people will be happy if they get what they expect. So don't fail to disclose that a tumor test may have implications for germline. Look for hereditary or germline in the test description to ensure that you're ordering the right type of test. And choose to use labs that give sufficient methods details that all relevant variant types are going to be detected. Also consider your lab focus and expertise. Although a lot of somatic labs are offering germline testing now, they may not be as experienced in variant interpretation. They may not be providing all the extra services, doing data sharing, etc. All right. I am going to skip over these practice resources so I can get to your questions. But if you have concerns about whether a gene is truly associated with cancer risk, Clingen is your best resource. They use a variety of data to give limited, moderate, or definitive classifications to different gene disease pairings. And this is a really excellent paper if you want a more in-depth view of what I was discussing regarding how your tumor tests may inform germline risk, what to consider when you're doing that tumor genomic profiling. All right, so I'm going to leave the final thoughts slide up while I address any questions that came from the audience.
Right. And Kate, if you don't mind, I actually am going to go ahead and move to that next slide just so I can pop those questions up as they come in. While we're waiting, and I know we've already got one in the chat, but So where are we at with precision medicine in terms of when a patient finds that they have multiple genetic indicators? Are we getting any sense of how those might interact and how they might increase risks? I mean, clearly with the BRCA1 and BRCA2, there's a lot there, but how about with some other indicators? And then I guess along those same lines, are we able to get to the point where we can make any specific, say, lifestyle recommendations, more than the broader eat healthy foods and don't drink and smoke sort of thing, but that might be specific to genetic test results?
Yeah, so thinking about low-level risk
Mhm.
germline variants or the polygenic risk score, I think we're very close. There's a lot of interest in that. There already are some clinically available tests that address that in the breast cancer realm and in the prostate cancer realm, albeit with significant limitations at this point. But groups like Clingen are also investigating this because I think that really is the next step in understanding our constitutional cancer risk. Right now, those sorts of tools are incorporating both the genetic information and the clinical information, like what is the family history? Has a woman had an abnormal biopsy, et cetera? And there's not good data that the polygenic risk adds anything to those clinical factors. But what this is probably going to look like is risk stratification for, who are the women who can start mammograms at 50, as we currently recommend for average risk women, or who really does need to start at 40 and those sorts of things.
Gotcha. All right. Thank you so much. We've got a question. Do you recommend a patient have a confirming test from a different genetics labs before prophylactic surgery is done? Thank you for that question.
If a variant is identified on a somatic test, whether that be a tumor test or a cell-free DNA test, and we are concerned that it may be germline, but it hasn't been confirmed in a lab that does dedicated germline testing on a separate specimen like a blood sample, then yes, I recommend confirming that test before any prophylactic surgery. If the patient had germline testing from lab A, those tests are usually, they're very specific. There's very low false positive rates. And so there's not a need necessarily to reconfirm testing from germline test A, lab A with germline lab B.
Great. All right. Thank you. Another question. Was the patient in the case example notified that she did not actually have the BRCA1, 2 germline mutations, and how was this resolved? I wondered the same thing.
Great question, and I wish I had a more satisfying resolution. So I was scheduled to see this patient, but once I started prepping for the case, I immediately contacted the oncology office that had ordered the genetic testing to explain the situation. They did take the step of immediately informing the patient, but the patient then chose not to attend her genetics appointment with me, and I don't know if that's because of lack of trust, because of confusion, because of overwhelm, because it was a real short interval. So the ordering oncologist's office has been informed of the appropriate testing to order, and they will order confirmatory testing or repeat germline testing for the patient when she returns. But she has yet to do that at this point, and it's been about 3 months since all of this initially happened.
Gotcha. Thank you. The American Society of Breast Surgeons recommended in 2019 guidelines that genetic testing should be made available to all patients with a personal history of breast cancer. Is this done at your hospital?
That is a great question. The short answer is no. We still follow NCCN as well as individual patient insurance guidelines about ascertaining those patients. I do want to point out that the ASBS recommendation essentially cited one article, and that article came from a genetic testing laboratory group. It considered the overall yield of people who did and did not meet NCCN criteria, but they didn't break that down by whether those were actionable results or even whether those results were expected to explain or not explain the patient's phenotype. For example, they included as actionable MUTYH heterozygotes And there is clinical action to that. We recommend that folks with MUTYH heterozygous variants have their first colonoscopy at 40 instead of 50 and repeat it every 5 years. But that's it. That has nothing to do with a patient's breast cancer diagnosis. It's really incidental to the reason for testing. So I don't think it was fair for them to include that as an actionable result within this critical time period of having a new cancer diagnosis, trying to make treatment decisions, et cetera. So I personally think that that's a flawed guideline that was based largely on an industry paper that had some conflicts of interest. And our institution is not doing that.
Sorry about that. Thank you for that very thorough answer. We're going to take just 2 more questions and then go ahead and wrap up. Regarding pharmacologic genetic testing done to avoid using specific drugs in particular population or need to modify dose, are these tests different than the kind of genetic tests discussed here?
Yeah, so different in 2 ways. The first way is just that an individual genetic test is unlikely to cover both of those types of risk, hereditary cancer risk and pharmacogenomic risk. The second difference is that it's uncommon to use next generation sequencing for pharmacogenomics. It's usually more cost effective to
who have lost up, Kate. I'm sorry, we lost the last about 7 seconds of what you were saying there.
I apologize for that. So in addition to just not being on the same panels, pharmacogenomic testing is typically genotyping rather than next generation sequencing because it tends to be more cost effective to narrow down onto specific pharmacogenomic variants of interest.
Great, thank you. And then this last question, and I'm sure I wondered about this as well, and I'm sure others did. What is your opinion on all the new genetic testing available through to the general public right now, Ancestry.com, 23andMe, et cetera, and how to act on those results if something does come up?
Great that's question. A fabulous question, thank you. So first thing is that you need to pay attention to the difference of, is this something reported by 23andMe or Ancestry? Because those tests are FDA regulated versus is this raw data that the patient has obtained from one of those services and then taken out to a third party, like Promethease is one of them, have they run it through Snippedia? That is not validated. That has a high rate of false positives because the raw data doesn't obtain all the same quality control metrics as the things that Ancestry and 23andMe actually report. So anything that comes from one of those third party or the raw data has to be taken with a huge grain of salt. Even the stuff that is reported though by Ancestry and 23andMe is limited. They are not doing sequencing. They are doing genotyping for the most part. And their reporting is restricted to only specific variants of interest. So for example, there have been over 100 pathogenic variants identified in BRCA1 and 2. 23andMe looks for 3 of them, the 3 Ashkenazi Jewish founder variants. So while a positive result for one of those is likely accurate, they are validated to report that they know what they're looking for. A negative BRCA1 and BRCA2 report from 23andMe is not informative for someone who has high cancer risk because chances are if there's hereditary risk, it's not one of those 3 variants that were identified or looked for.
Gotcha. That's very helpful. Thank you. Well, I know I still have questions. I'm sure our audience does as well, but we are over time. So I want to say thank you. I want to say thank you, Kate Foreman. This has been incredibly informative, and we really appreciate your time and expertise today. I want to thank the people of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. I want to thank our team, Mary King, John Powell, Jason Paylor, Veneranda Obore, Oliver Marth, and Andrew Dodgson for all the hard work that they put into each and every one of these lectures.